This conference will now be recorded.
Good evening, everybody. It's John Antonucci. With help from the other moderators in the group, Len and Rick, and who else is backing me up here tonight?
That's it. Ben is on vacation.
Ben is on vacation. Okay, I'll be moderating. It's September 9th, 2025, and this is the Advanced High Risk Recurrent Prostate Cancer Discussion Group. We have some sponsors to thank before we get going. They are Bayer, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis, none of which require us to say anything positive about their products. We're not going to give medical advice, but we have an awful lot of personal experience to share with each other, and hopefully we'll exchange a lot of ideas that you can go back and talk to your treatment team about. We generally start our groups with the newcomers, and if you're comfortable with it, I'll ask you a few questions. We'll get some basic information and get some feedback to the guys. I'm going to start with Paul. I met Paul last week in Men Speaking Freely. He came briefly. He came to intermediate. We got enough of a history to know that he was recurrent and belonged with us. So we're going to continue, Paul, along the line of getting some of that history. Now, we know that you're from Arkansas. I don't know your age, Paul.
I'm 70.
70 years old from Arkansas. Diagnosed in 2024 when his PSA popped up to 10, and he got a radical prostatectomy at the beginning of 2025, which had positive surgical margins and positive seminal vesicle invasion. He had about a 2% pattern 5, and so I think the overall Gleason was 4 plus 5. Is that correct, Paul?
I can't remember. I think it was 4 plus 3. It was high enough that it was worrisome.
I think it might have been 4 plus 5, so we're going to treat him as a high-risk person. He's had incontinence since his prostatectomy and has an artificial urinary sphincter. The PSA dropped precipitously after his radical prostatectomy to 0.04, but has popped back up already to 0.15. And so I'm going to pick it up from there and ask you if you've had any MRIs or PET scans or bone scans or other diagnostic tests.
Yes. Let's see. I had a PET scan yesterday, which came out showing no metastasis and no whatever activity in the prostate bed, which is good. My PSA actually, I'm 2 weeks into Orgovix, and my PSA is now down to 0.04 again. So it's bumped back to what it was in March. So that sounds like good progress. I had a prior PET scan before they did the operation. I had a PET scan that showed similarly no metastasis.
Similarly showed no metastasis, but,
yeah, but
disease in the prostate gland. Okay.
Prostate, yeah.
Did you get any kind of genetic tests?
I don't think so. Not that I'm aware of. I didn't think to ask for it.
Even though you're not metastatic, your risk level, it seems to me like it would be a good idea for you to get testing to see if you inherited any at-risk genes. Do you have any family history of cancer?
Yeah, my brother died 2 years ago of glioblastoma. I had testicular cancer when I was 35, and my mother had colon cancer. My sister had cancer. You have plenty of family history, but no prostate cancer I'm aware of.
So we've got a glioblastoma and colon cancer in the history, and there was one other one. I missed it.
Let's see, my mother had colon cancer. My sister has skin cancer.
Skin cancer, okay.
Yeah.
A melanoma or what
A
kind of
melanoma,
skin
yeah,
cancer?
this just keeps getting pieces hacked off.
Okay.
And testicular for Paul, John.
Personal history of testicular cancer.
Yeah, I
That
had
was you.
seminoma when I was
You had a
30.
seminoma and you had very good treatment results, right?
Yes, I had radiation and orchiectomy. I've had no recurrence since then. I had CAT scans for the first 5 years after the operation.
Okay, great. That's great. And who do you identify as your cancer doctor now?
Well, that's a good question. uh, I had it was removed by, I'm being treated at UAMS, which is the University of Arkansas for Medical Sciences. It's the main teaching hospital here. It's the, the Center of Excellence here in Arkansas, which thankfully is just a couple of minutes away from my house. I was
Good.
treated, the prostatectomy was by a man named Dr. A.D., who's trained in, also he's a genital urinary oncology specialist. And he did this.
Some urologists also subspecialize in cancer. They call themselves uro-oncologist or onco-urologist or something like that. So your doc is like that?
Yes, yeah, and he did the operation. I've seen him a couple of times, and won't see him again until November. Um, and another doctor, a urologist, put in the artificial sphincter a few weeks ago, and that'll be activated. And I've been referred to
The whole last part of that sentence was lost.
Oh, I'm sorry. I've been referred to the Proton Center for Radiology, Radiation,
Okay.
and that's supposed to be starting. That's like he put me on the Orgovix, and I had my AUS installed by another urologist
Yeah.
about 3 weeks ago, and that'll be activated in about 3 weeks.
Have you met
That's
with
that's
a
the
radiation oncologist at all?
Yes, yeah, that's the guy. He's the guy at the Proton Center. He was great. He
Yeah.
was really useful. Probably spent close to an hour with me. He was great.
What's his name? Do you recall?
His name is Cordova. He's a MD, PhD from Emory, and just was very helpful and detailed. And we're going back to research, like we've been going.
Emory in Georgia?
Yeah.
Oh, okay.
So that was
So,
interesting.
so your present situation is you're just starting on ADT
Yeah.
and you are getting a response. Your PSA is down to 0.04 again and maybe heading down even lower. And you've already had a discussion with Dr. Cordova, and the two of you decided to use proton therapy against your prostate. What,
Yes, that's
like,
correct.
what would they aim at? The prostate bed itself, assuming you have a recurrence in the prostate bed? Because
That's
nothing showed up on the PET scan, and so we commonly assume that recurrences are in the area of the prostate bed. But is that going to be his assumption moving forward?
That's my impression. I'm going to have a CT simulation scan next week, where
Mm-hmm.
they'll define exactly what they're going to be radiating. He's proposing, I think, a 40 session,
Okay.
something like that. And since they did the PET scan first to see that there wasn't metastasis, to determine if there was anything outside of the prostate bed.
Yeah. So what you have going for you is that you're not metastatic according to a PET scan, which is a pretty sensitive test, which means that whatever is growing in you is too small for a PET scan to show. But then on the negative side, you have a little bit of grade group 5 high risk pathology in the original. And we know that your margins were positives and they didn't get everything.
Right, exactly. They took out the seminal vesicles. I mean, as I mentioned, when the head of the top urologist calls you about 5 minutes after your biopsy drops, and it's like, oh, whoops. He said, oh, this is a surprise. So that's kind of fun.
And what questions do you have at this particular point? You have at least a tentative plan. Hopefully, you'll get a chance to get some gene testing.
I'll ask for that.
What would you like to learn from the group or discuss with the group?
One thing I'm curious about is how long I should wait after my AUS gets activated to have radiation, because I had been talking about doing it right away, but the ChatGPT and Gemini Oracle says, wait another month till you get really healed from the insertion to start radiation.
So the actual date of the installation was probably sometime in early
It was like
August.
It was like August 20th, something like that. It's been about 3 weeks now.
Okay, so first question.
And September 28th is the date of activation.
Okay, so first question. Three weeks ago, something like that, he had an AUS installed, and he's wondering if he should wait a long time after that surgery before getting started on radiotherapy. Who's got anything to share about that?
When was the surgery? What was the date of the surgery, please?
I have to check. I think it was about August 15th. It's been about 3 weeks. He wants to wait
I'm
6
sorry.
weeks. The prostatectomy?
The date of your radical prostatectomy, yeah.
That was January 31st.
Okay.
Does anybody know? We don't have too many people with AUSs. I'm one of them, but is there any reason to wait several months after that before doing any radiotherapy?
What did you do, John? Dr. John, did you have your AUS installed before you had salvage radiation or after?
After, about 9 months afterwards. Radiation therapy, there's not going to be a lot of it aimed into your scrotum. The AUS is a device where there's a pump that sits in your scrotum, and then there's a plastic tube above that, and a little reservoir of water that's to the upper left or upper right of your and behind your pubic bone. Some radiation will probably be going through that. I assume that the plastic is transparent to radiation. I'm not aware of anything that would suggest that the radiation will heat up or damage that. Anybody got any knowledge about that? I guess you're going to have to discuss it with the radiation oncologist. I don't know of any reason. You're talking about getting your proton therapy in the middle of the fall.
Yeah, maybe late October or something.
Late October, so that will be 2.5 months. That seems like a pretty decent amount of healing time to me as far as your own personal tissues. And as far as I know, the plastic is not going to absorb heat from the radiation, but I'm not an expert on that particular question.
I'm looking forward to having my AUS activated. That's going to be a happy day. I think I'm going to.
Yeah. Oh, yeah. Yeah, that'll be good.
Get rid of the diapers. Yeah, it's a bore.
Chances are that you will probably get rid of that, but still have to use some small pad.
Yeah, that's what I'm expecting.
John, do you remember? John, do you recall if Jimmy had his AUS before or after? Just looking at my notes.
I do not know. I think after.
You think after? I got the date of when he AUS, but I don't have date of when they did the salvage. Or maybe they never did no, he didn't do salvage because he was on that trial where he got docetaxel, remember?
Oh yeah,
Um,
he did. He got
and
those
so,
texts.
and he's never had to do salvage, so he wouldn't know either.
Usually they give you about a year after radical prostatectomy and trials of things like physical therapy or medications before they give up on you ever getting continent and do the surgery. In your case, they must have thought that you were just never going to recover, so they did it after only 6 months, right?
Yeah, I lobbied for that because I had absolutely no change in continence, and I think there was enough removed of the nerves that they thought it probably wasn't going to come back. And it's been 9 months now, or 8 months, and there's no sign
It's
of any
never.
change.
Yeah. I see.
But I
Did
wanted
you
to lobby
want to?
for it in case I needed radiation to get it before radiation, and they responded
Yeah.
to that. So I appreciate
Okay.
it.
Is there any room for discussion about what type of radiation therapy to have, or are you quite settled on proton?
I don't know the difference, actually. I think it sounds like us have a friend who's actually a radiation physicist. He said, they like to use their expensive new machine, um, and I don't really care. It's socialized medicine at age 70. So um,
Are you going to get insurance reimbursement for it from
I should be.
Medicare?
I'm on Medicare, so I think I should. Yeah, I think I should be mostly covered. I'm
Is
hoping.
proton therapy universally accepted now, guys? Does anybody know? As far as Medicare is
Hmm,
concerned?
I think so, but you should definitely verify with your what type of additional insurance do you have?
I just have Blue Cross Blue Shield. I don't have Medicare Advantage. I just have the regular
Regular
plan.
So
Medicare?
you have Blue Cross Blue Shield. Is it traditional or is it Advantage?
It's
A
traditional.
regular.
Okay,
Just make double
so
sure. Just make
That's
double
a
yeah,
very
sure.
good thing. Yeah, I would hate to assume that it's covered and find out I've got a
right.
$60,000
Yeah.
bill.
So
Yeah.
I would definitely verify that they'll cover proton. They are some of the time, but some of these BCBS programs can be really difficult. If you don't do proton and you finish up
Mhm.
doing photon, there's really no difference. There's no
Okay. Yeah, that's
evidence
good.
to
Yeah.
show.
SBRT, EBRT, IMRT all probably will have the same benefit for you. The
Okay.
most
Well, thank
convenient
you.
of
That's
them
very
all
useful.
the most convenient for you would be probably SBRT because it would be the fewer number of sessions. But in terms of your outcome and survival, through our experience, you should get good response.
Yeah, I would say on that, Dr. John, that SBRT is pretty unusual for salvage because it's still experimental in terms of spreading it, across the pelvic girdle everywhere.
Across the
There are
whole
some
pelvis.
people doing it, but it's not. There isn't really an acceptable protocol. SBRT can also be delivered with proton too. You have Bill Yu had his hand up.
Uh, best of my knowledge, with traditional Medicare, you shouldn't have any problem. I would definitely check, as was recommended, regarding coverage. My doctor, I had Proton back in January. He said traditional Medicare has covered it for 20 years. There's a lot of trouble with Medicare Advantage getting coverage. I was initially denied, but got the uh, denial overturned on appeal. So
My
that's
older
my
brother
two
was a
cents.
doctor told me to stay away from Medicare Advantage. So it's good advice.
Yes, I think that's very good advice. I think
I
Rick,
personally have traditional Medicare. I'm happy that I have that instead of Advantage myself. Okay, thank you, Bill. Any other things on your mind?
No, I appreciate you taking the time.
Okay, well, thank you for coming in and welcome to High Risk Group. This group runs a little longer, by the way, than the other groups that you were in. We might go a good full 2 hours at least. So get a comfortable cushion if you're sitting down. We meet every week, but sometimes Monday at 8 and sometimes Tuesday at 6 Eastern time.
I had one other question for Paul. You mentioned this family history. Have you had a germline genetic test yet?
I haven't. I could do that.
Yes. We'd strongly recommend you do. The doctors probably should have scheduled it given your 4+5 and the family history, so that's a concern to us. I will put momentarily a link in the chat, which gives you access to a free test, a free promise test through Color in a trial that's being run by Johns Hopkins and University of Washington, Fred Hutch. It is not the largest panel, but it's generally pretty good. Do you have any cervic blood?
Cervical?
Yeah, from Central Europe. Do any of you
Oh,
access?
no. I'm a
Okay,
Northern
because
European.
there is a gene they don't cover, which can be problematic, but it's much more common in people that come from Central Europe. So we'll put that in for you right now. Get onto them right away because they're getting very close to their limit, and they'll send you a package. You just take a mouth swab, you send it back, and they'll set you up with a genetic test if you need it. The alternative is to just ask your radiation oncologist, tell him that you'd like a germline or inherited cancer test. So you choose which way to go.
Excellent. That's very helpful. Thank you.
Thank you, Rick. I told them to do it, but I didn't tell them how. Okay, I'm going to move on to Tom McIntyre. Hi, Tom.
Hi, good afternoon or good evening.
Welcome to group. Where are you from, Tom?
Chicago, Illinois, just a suburb of Chicago.
How old are you?
69.
And how did you find your way to AnCan?
Through the Mayo Connect, we saw that there was this forum for getting questions answered. So I thought I'd sign up and see what I could find out.
So
okay.
I'd like to give a shout out to somebody who's fast asleep right now, but if he listens to this recording, he'll hear a big shout out to Jeff Marchi because he's refers a lot of people from Mayo over to us on at PCRI this last weekend. Several people said they'd heard of us, but we don't hold his attention very well, as you can see in the icon right now.
Tom, tell us about when you got diagnosed.
I was diagnosed with prostate cancer in December of 2023. At that time, my PSA was 28. I had a biopsy done. I have a Gleason 9. I had a PSMA PET scan done, a bone scan, and an MRI. I had metastasis to a nearby lymph node, and I have a Decipher score of 1. So it was very aggressive. I have done genomic testing, and I have a thing called BRIP1. I guess it's very rare, so they don't know a lot about what to do with it.
You said
Is
that
that,
was genomic. It was done on your prostate biopsy?
Yes, it was. Yes.
and was that B as in boy, RIT1?
B as in boy, R as in Robert, I as in
India.
Indian, and P as in Peter, 1.
Oh, BRIP.
Yeah.
You know that
They call it BRIP1.
I got myself a whole list of genes that I have to refer to keep track of them, but that is not on my list. Have you had germline genetic testing also,
Yes.
family? And that doesn't have the BRIP1 on it?
That's where I discovered I had BRIP1.
Oh, it's a germline. It's a germline.
Yes.
Okay.
Yes.
It's an inherited.
Correct. I'm sorry.
But you also had genomic testing, right?
Yes. I had some
on your
genomic
tumor
testing
sample.
done and genomic.
Okay, and there's no other abnormal genes besides this one?
That's the one. No, that's it.
Okay.
So, Dr. John, the genomic was the decipher. I expect it wasn't a.
Oh, okay. So a decipher of 1. So so you have a decipher of 1 and a Gleason 9 to be concerned about, and 1 positive lymph node.
Right.
Was your Gleason 9 a 4+5, a 5+4?
I believe it was a 4+5.
4+5. Okay. Okay, so that's back in 2023 and probably going into 2024. So by now you've probably had some sorts of treatment, right?
Yes, I started on Orcovix, abiraterone, and prednisone with the prednisone in December of 2023. I'm able to tolerate it pretty well. I mean, I do have fatigue, and I do have hot flashes, but other than that, I'm able to tolerate it pretty well. So that's not a problem for me.
That's really good to hear. Was the Abby and prednisone started right away with the Orcovix or later on?
No, actually, the Orcovix started in December of 2023, and the abiraterone about a month later.
Okay. All right. So it's the better part of a year now, and you're still tolerating them pretty well. Do you have any idea what your current testosterone level is like?
It's low. I want to say, like a 4 or something like that. It's very low.
So you've had a very good result from your
Yeah, I've had a good result.
anti-androgen therapy.
Yes.
Okay, and whatever happened to that PSA of 28 as time went on?
Well, let me go through. I had a radiation treatment done in June of 2024, and my PSA became undetectable in November of 2024, and it's still undetectable.
Good. So you've put it to sleep.
Yes.
And the lymph node that was found on the PET scan, that was down in the pelvis?
Yes, it was. It was very nearby the prostate.
Okay. You new guys are kind of lucky, you know right off the bat about things like metastases and all that. Just a few years ago, you wouldn't have had that PET scan.
Right. Yeah.
So, how about social supports, spiritual supports, exercise, lifestyle things?
Okay. Well, yeah, I have an exercise program that I went to Northwestern Medicine that they gave me an exercise program that I do 3 times a week. And I also play ice hockey 3 times a week, so that I'm getting good exercise to help fight the fatigue.
Great. That may be partly why you're tolerating it, such a low testosterone so well.
Yeah.
Married, social
I'm married.
supports?
I'm married. My wife's very
Okay.
helpful.
Okay. Medically, any problems?
No, I was never had any problems until this popped up in 2023.
Yeah. Okay. And when are you going to turn 70?
Next September. I just turned 69 last week.
Oh, you just turned. Okay. All right. Very good. You happen to be a veteran?
No, I am not.
Okay. So who do you identify as your current doctor for
My
this?
medical oncologist is Dr. David Vanderweel at Northwestern Medicine.
Oh, okay. Very good. Right, Rick?
Yep.
How often are you seeing him?
Every 3 months.
Okay. All right. You have things nicely in hand now. What questions do you have, or uncertainties, or anything?
My oncologist right now, he's recommending I stay on the hormone treatment for 24 months. So that means next January would be the end. Then he's saying I should get off and then like see what happens. And I'm not very comfortable with that. So I got a second opinion. I went to Mayo Clinic and saw Dr. Heath, and she actually said I should stay on hormone treatment indefinitely. So and she said there's an overall survival benefit for staying on it, and it would be 3 to 4 years before I became castrate resistant. So that's my quandary right now. My current medical oncologist is saying get off after 24 months because that's what the Stampede trial says to do. And then I got a second opinion, and she's saying to stay on it indefinitely.
Okay.
So I was wondering if anybody else has been in my situation where they were on hormone treatment for 2 years and then got off, and how that went for
Many
them.
of us have been in that situation, yes. And I can remember hesitating when my 24, or in my case, 28 months came up because I was reluctant to go off. Who can share their experience about getting through the first couple of years of hormone therapy and then deciding whether to go off? Jack?
I was just the opposite of you, John. I couldn't wait to get off. And I was on it for close to 24 months, and I of both darolutamide and Orgovyx, and I just needed a break because I was feeling terrible. And my medical oncologist encouraged me to give it a shot. I'm in my 6th month right now. I'll find out in 2 weeks what's cooking. PSA last time was 0, and my testosterone and estrogen is 0. But, I feel better, but I don't feel so great because my hormones have not recovered. But I feel better than I did on the medication. So I have had 2 medical oncologists. One school of thought is stay on it for life. The other one is give yourself a break, have some quality of life. It's really one of these very subjective assessments that medical oncologists make based upon whatever experiences they've had that make them more amenable to one school of thought or the other. It's hard to know which one is better for you or for me.
Yeah.
Rick, would you like to take the other side of the debate as far as getting off?
Not really, because I think I tend to feel that it makes sense to take breaks. It's interesting that you went to Dr. Heath because we really love her, but I didn't realize she was that position. I have a couple of clarifying questions, and I have a suggestion.
Okay.
Was that single lymph node the only place they've ever seen metastasis?
Yes, it is.
Okay. Well, there's a doctor that many of our guys see who's local to you, and that includes board member. And I think it would be worth your while sitting with him.
Okay.
it's Dr. Russell Schmulowitz at University of Chicago. We'll put his information in there. He's a
Okay.
very popular item in this group.
Smolowitz is my oncologist. I have good things to say about him.
He's a popular item in this group for a number of reasons. One of which is he is empathetic to holidays. Secondly, but you're tolerating your Abbey and your Orgovyx well. He's
Yes.
also empathetic to monotherapy. So, and we've had several people who have done real well, and there are people sitting here in this group today who have done well on monotherapy darolutamide, meaning that's all they're taking. At the same time, you know, if it ain't broke, don't fix it. If you're doing well with it and you're managing, you know, you're playing ice hockey. Did you say 3 times a week?
I'm sorry. Play hockey?
Well,
Yes.
3 times a
3
week?
times a week. Yes.
Well, you should rent a room there. Maybe they got a storage room for you. You could move into 3 times. What time of night are you playing at? Like 2 a.m. and 3 a.m.?
No, unfortunately, it's at like 6:30 in the morning till 8 o'clock.
Oh, jeez.
Okay.
That's at 69 years old playing hockey 3 times a week.
Unbelievable.
I played room hockey in my late 40s, and I couldn't even keep up with those guys.
Well, we've got a fellow who, if you come to our Men Speaking Freely, Dr. John will give a plug to Men Speaking Freely in a minute. If you come to our Men Speaking Freely, the second meeting of the month, the guy who leads that meeting played ice hockey goalie for years and years, and he still wishes he did. So, look, it sounds like you're doing great, but I do think if you want to put a second, you know, Van der Weyler's very good. He doesn't have a lot of personality, but he's very, very solid. I'm trying to be nice. Dr. Russell is great. And I think he would complement, and also you don't have too far to drive to go see him in Hyde Park.
One of my concerns is if I do get off it and my cancer reappears, will it be more aggressive when it comes back?
I think we're guessing now, okay, because we don't know. I think it will be the same. Because you really haven't had this disease long enough to have much in the way of new mutations. Now, I don't know too much. I don't know anything about this BRIP1. So it may, once I learn about it, I may have a different opinion. But I think that if it did, it would be the same, and it would be hormone responsive, very similar to what you've already gotten. I don't know if anybody else wants to hazard a guess on that question. Len's got his hand up. Maybe you could both bring up your point and try to answer that one, Len.
Yeah, Tom, did they explain to you the advantages to taking a drug holiday?
Oh, no, not really. All he said, what he really did is he just stated the Stampede trial and said that they went 24 months. Yeah. And that was really his rationale behind it.
Right. So, you know, the side effects of hormonal therapy, they can tend to be cumulative the longer you're on them. So the rationale for taking a drug holiday is to improve your bone health, your muscle health, your cognition, and your cardio health.
Yes.
Okay, so there's that. And more recently, we're hearing of an approach to prostate cancer they call adaptive therapy, where they believe that it may not be a good idea to beat down your sensitive cells to the point of obliteration, because you're going to be leaving behind only resistant cells, which are going to be more difficult to treat. Okay. So, you know, that's another argument for taking drug holidays, and for allowing a certain population of sensitive cells to continue, to crowd out the more resistant cells.
Okay.
Those are things you can talk about with your doctor.
Okay. Thank you. Very
By the way,
helpful.
by the way,
Very
John,
good
just
points.
briefly,
Go ahead,
BRIP1.
Jack.
Let me just say a little about BRIP1. It's, I looked it up, and it's really only for breast cancer and ovarian cancer and a Fanconi anemia, if you remember that, blood dyscrasia, bone marrow failure. So I don't think it
Mhm.
applies to you, Thomas.
Okay.
Okay,
Pretty
good to
certain it
hear.
doesn't.
So at least that's not another notch on the high risk side. There is another hand up. Let me see. Oh, it's Jeff.
Did they target the one lymph node? I'm
Yes.
assuming?
Yeah.
Okay.
I had SBRT done.
Well, that's a great question you raise, and it's very difficult to give an answer to. Your Decipher score predicts that you are going to be metastatic by 5 years. Does that mean you need to stay on treatment for the entire 5 years, or you can take a break, let the cellular changes that Len was talking about take place? I don't know. At 2 years, you probably should get another DEXA scan and make sure that the treatment is not stripping your bones despite playing hockey.
Mm-hmm. Okay.
Other comments or ideas?
Yeah, I have something. So one of the reasons why there is a hypothesis that if you stay on these ARSIs for too long, the cancer becomes resistant, and frankly, we can't find good treatment, so it promotes it to morphing quicker. And so one of the reasons that we always tell patients to speak to their doctors is for their position on that. If it were me, I would certainly want to get off and get back on again to try and keep the cancer off balance. And you can keep the cancer off balance in a number of different ways. You don't have to stop altogether. For example, you could go on to monotherapy, like we talked about before. You can switch the drugs that you're taking. But certainly, if you can manage it and your doctor's in agreement, I don't think that taking a break is a bad thing. And one of these days, I'll get to debate that with Dr. Elizabeth.
Yeah.
Okay.
Who else has their hand up?
Dennis.
Dennis. Hi, Dennis.
Hi, yes, I've been on, it's also called intermittent therapy. You may have heard that term, where you take a break and then you monitor. Probably, the first year or so, keep getting your PSA checked every 3 months. No, I wouldn't go any later than 3 months. You just don't know yet. You don't know how you're going to, and everybody's different with this, how much time they get. The other thing would be good to know, but you probably didn't do it, was a base level testosterone.
No, I didn't
get?
No, I didn't get a base level.
Good to know, so you can use that as a benchmark
Mhm.
and see how you're recovering to get. That's the other one of the main reasons for getting off the therapy for a while. But that's just want to make those couple of points for you.
Okay, thank you.
They can go on. I'm Gleason 9, been doing this for 9 years. So,
Great.
and de novo metastatic hit diagnosis. So,
Okay, thanks everybody, and Jack,
Thank
thanks
you.
for looking that up.
Thank you.
Okay, keep coming if you would like. You'd be welcome.
Are you signed up, Tom? Are you getting reminders?
Yeah, I signed up today.
Okay, great. Oh, John, very quick
Yeah.
promo for Men Speaking Freely, because Tom may not have signed up for that one.
No.
First and third Thursdays of each month, we have a open discussion group where we don't talk about any of these technical issues. We just talk about feelings and coping and being men with illnesses.
Okay. Thank you.
Richard, are you still here? Not
Which one?
Richard, Virginia. Richard B.
Me or Virginia? Which one?
Maryland Richard, not Virginia Richard.
Okay. Yeah, thank you.
So I know you from the other group, but you've never been in this group before, right?
That's correct.
Okay, let's get a little information for this. How old are you?
79.
And where do you live?
Just outside of Washington, D.C., north of it, northern suburb, Silver Spring, Maryland.
Okay. Did you say you were an AS or intermediate before you came to us?
Well, I started with AS, then went to veterans, and then went to intermediate. And then last night it was recommended that I step into this group.
Okay. Why? What happened? You advance in a way?
I'll just give you some background. I've been diagnosed with prostate cancer for 6 years. Finally had treatment, SBRT, 16 months ago. And it was a situation where the cancer was wrapped around the urethra. And it's been 16 months since treatment. The only little caveat there was that after the first session, I had COVID, but they continued through it. So I went through treatment with COVID with everybody in hazmat suits. That could be interesting. Anyway. Yeah. So now 16 months later, the good news is that the PSA is declining. My highest was 11.7. After radiation, the first PSA went down to like a 5, and then it declined again to like a 3.7, then a 2. But what I've experienced is with urinary functions, it's a restricted flow, discomfort, and now been experiencing urge incontinence. I've had 2 bladder ultrasounds, and there's nothing major, just a little bit of retention. But as a side note, my primary physician wanted me to have a blood test, totally different reason and rationale. Well, what came back in the blood test is something that I'm just curious to see how it's related to prostate cancer. I had 4 measures that were unusual. I had a high, I guess it's called creatinine, very high reading there. Had a high reading of blood urea nitrogen, had a high chloride reading, and a low EGFR reading. As I looked that up, I mean, this is just very, very recent. So I looked it up, and it can indicate a blockage or kidneys not filtering urine very carefully. So I was advised by my radiation oncologist to meet with a kidney specialist. Boy, believe it or not, trying to get an appointment with a kidney specialist at Johns Hopkins, the only opening was July 2026. So I found another one that's out there. But I did get one outside of the Hopkins system, and it's going to be January. The primary care physician, I asked him, I said, is there any urgency with these readings? And he said, no, not really, but it's just wise to go ahead and get it checked out. So everything else is looking like these might be indicators of kidney disease. So my question is, has anyone who has experienced prostate cancer post-treatment had any impact on their kidneys in any way, shape, or form?
And you're not diabetic, are you, Richard?
No, sir.
Diabetes in the family at all?
No.
Okay.
What were
So
your
your
numbers?
prostate cancer itself, your PSA is down to 2 now, and so are you stable cancer-wise?
My next appointment with radiation oncologist is in November, and it seems to be stable. I mean, he likes the fact that it's going in the right direction. It's declining, so I was a little worried about that it didn't drop significantly, but he seems to be comfortable with that. He is Dr. Stephen Greco. He's with Hopkins, but he's also head of radiology at Suburban Hospital, which is outside of Washington. And it's Hopkins bought that hospital some years ago, so he's head of radiology there.
Do you have any gene testing ever?
Yeah, it was negative. I forget what's the. Oh yeah, you can remember the name of it. It's one where you just do the little urine test and the doctor take it. Is there something called? Is there a climax test? Is something like? Is that name right? I can't think of the name of it.
Let's
But
see, what might sound like.
It came back, nothing to worry about. Let's put it that way.
Okay. I can't think of what sounds like that. Okay, and you're a veteran, I know, because I've seen you in group.
Mm-hmm.
Okay, so something is going on with your kidneys. There's no known primary or diabetic renal disease that could be making your kidneys fail to get rid of your creatinine and BUN the way they're supposed to and reduce the filtration rate of your kidneys. You suspect there might be something, maybe some back pressure from constriction of your urethra, it sounds like.
Only based upon some little Google searches. This is all without seeing the kidney specialist yet.
Did they do one of these, what might be called a urogram, where they fill your kidneys and your readers and your bladder and your urethra up with dye and take pictures of it?
Wow, no, I've just had the bladder ultrasound.
That might help a lot to determine whether, if you have a blockage, then the pressure builds up behind the blockage. So the ureter coming down from the kidney would be swollen. But if it has nothing to do with the piping and it is actually in your kidney, then you might have something going on in the kidneys themselves. As far as the relationship with your treatment, your radiation probably went nowhere near your kidneys themselves, although it did shoot at your urethra area.
Correct.
So if there's some damage there. And you're not on any medications now for your cancer?
The medication I have is tolterodine.
Tolterodine, yeah. Is that helping your any?
Yes, a little bit. And then alfuzosin. Is that right? Pronouncing it right? Alfuzosin. Alfuzosin. 10 milligrams.
Okay, that must be like doxazosin, I guess. Must be in the same family. Len, any comments about the medications themselves? They don't strike me as renal toxic, but I don't know alfuzosin, and it's probably like doxazosin.
Yeah, it's in the same drug class, and I'm not aware that they're renal toxic.
Okay.
What was your GFR, Richard?
Let me go back again. Let's see. Do you want me to find the reading? It was a low GFR. I can.
Oh, yeah, that's all you have, low. It doesn't have a number.
It probably does. Just keep talking. And I'll try to look it up here in a second.
Yeah. Or your BUN or your creatinine level, that would help too, just to see the extent of the kidney function.
Yeah. Oh, here we go. Let's see what's this. This is no. The BUN is 28.
That's not too bad.
No, the Dr. John, how did you pronounce it? Creatinine?
Creatinine.
Creatinine. That's a 1.76.
Okay.
And then the EGFR is 39. And the BUN, maybe that was okay. The BUN is 5.0. That's not bad. Oh, chloride. And the only other reading was chloride, 108, moderately high.
Okay,
So
these aren't too scary.
49. That's getting them pretty low. I don't know. What your doctor said, don't worry about it.
Well, the only reason I bring it up that way is that I was concerned about how long it took to get an appointment. So I went back to my primary care and I said, "Is there an urgency on this? I mean, do I need to push to get an earlier appointment?" Because I said the earliest I can get is January. He said, "No, you should be fine with an appointment on January 14th of next year, just a few months away."
I was wondering, Paul, if you would make any comments about whether this sounds like a renal or a urological problem and whether he's fine waiting until January.
Well, I think what you mentioned, an upper tract study, a renal ultrasound would be really helpful. And I'd like to know what your creatinine was, if you know, 6 months ago or sometime in the past. Has it doubled in the past 6 months? Because are you on an upswing or are you stable? So I'm uncomfortable with saying just hold off for 4 months without another follow-up set of labs to be sure this isn't an upswing. You're just getting a point on an upswing of a problem. And you said with your bladder ultrasound it was okay. Do you have a number?
Oof.
I mean, was it 100?
No, it
300?
wasn't real high. The retention, I had some retention, but it wasn't significant, is the way that the radiation oncologist worded it. But I don't know.
You don't remember a number?
10 milliliters?
Oh gosh, yep, that would be perfect. Yeah, I mean, we wouldn't call that retention.
Okay.
So that's when you said retention, I was a little concerned.
Okay.
But getting a one, do you know what? You probably don't know what your creatinine and BUN were, say 3 or 6 months ago.
No, sir. This was the first time that I had a blood test with this amount of
yeah. So
results.
I'd say ask your PCP sometime between now and January to get another set, just to make sure they are stable at that level and not escalating.
Good point. Okay, I'll take your advice. Thank you.
And ask whether renal ultrasound might be done even ahead of time, because it's probably going to be ordered in January. Thank you, Paul.
Yeah, thank you.
Okay, and as far as we know, not related to prostate cancer or treatment. Do I have anyone else that's new in the room?
I've had my hands up, John.
Oh, I didn't see it. Go ahead, Mark.
Richard, I had trouble peeing, so I'd have to pee often, and get incomplete voiding. But that went on for years, and then all of a sudden I got really sick. I was still peeing, but what happened? There was enough of an obstruction. The urine backed up out of my bladder all the way up into my kidneys, and I had total kidney failure.
Oh my God.
And they installed nephrostomy tubes, which they go in through your back and put a tube into each kidney that then drains down to a bag. And it took a little while, but that took care of it. But just be on the lookout for something like that.
Oh, okay. And then did you have a high volume on your bladder ultrasound? Did that give a high reading for retention?
Not particularly high.
Okay.
That was a little surprise to everybody, but I guess it can happen.
Okay. Yeah. All right. Appreciate your comments. Yeah.
Thanks, Mark. Okay, I'm going to start down our list of regulars. As long as we've got all the new guys settled in. Jerry Smith, Jerry and Cynthia, do you want to catch us up to date?
The only thing new to report is I've got an appointment with a medical oncologist next Monday. And as of first reporting and everything, I haven't taken any steps, any therapies until I get this second opinion. And that'll happen next Monday. And after that, as I've been kind of sitting on this, I'm sure I'm going to have to make some decisions.
So we called the medical oncologist and we asked him if Jerry should need a testosterone test, DEXA, new PSA, and some preliminary labs, since the last one he had was
4 months ago.
4 months ago. And they said that when Jerry gets there and the doctor assesses him, then the doctor will order whatever he needs.
Yeah.
So we don't need them going in at this point, but we have that all on our list to ask.
Okay. That was my fault. I told them it might be good, since it's 4 months, to go in with a new PSA level, but the doc wants to see if there's anything else. It means you won't know during the discussion itself next week what your current PSA is.
Yeah, I have a primary care physician in Florida who is just, we set it up so that when we were in Florida, we didn't have to call back to Rochester for issues. He did a PSA test in his office and got the readings while I was talking to him. Is that unheard of?
I never had anything like that done. Paul, do you know?
Yeah, there are state-of-the-art PSA testing that you can get the results in 15, 20 minutes. So I think it's becoming much more popular, if you will, and it's pretty accurate as far as I'm aware.
Okay, so that's what I was wondering, whether that was going to happen next Monday or not. But I don't have anything more to report other than that appointment.
Okay.
So, question for you. Is it Dr. Guercio that you're seeing this week?
Yes. Yes, it is.
Yeah. I mean, I do tend to agree. I mean, I tend to agree with John that another PSA, given the last one was, when was that, 0.24? How long ago?
Back in May.
May. Yeah, I mean, it would have been helpful, but see, the problem is that he's going to do a PSA. He's got to do a PSA. I can't see he wouldn't. The good news is at least it'll be consistent, because you can try and get it done at the same lab, talk to him about where you had the last one, and try and keep the labs consistent. So he may finish up giving you an order so you can go back to the same test. If he takes the test and runs it at Wilmot, because I'm assuming the last one didn't get run at Wilmot, correct?
No. No,
So
it did not.
if he takes it, ask him for an order and get simultaneously a test done at the old one, at the first place you went to, so you can see if there's a variance between the two. You follow what I'm saying?
Yes, and that sounds really reasonable. The difficulty I see, and maybe it isn't, is Rochester has two competing medical networks, and I'm jumping network to go see him.
Yep.
All the rest of my doctors have been in the other network, including the labs.
Yeah, but you really need that GU medical oncologist, so you're going to have to stick with Wilmot for that. And frankly, you only need to do this synchronistic exercise one time just to see where the difference is, and hopefully you can figure out a way to do that. But it is helpful, and then you're just going to have to come back and tell us. But I mean, if your PSA was up to 0.24 in May, something is in your future. We don't know what. So come back after next Monday, or come back next Monday night, because we'll be here next Monday night, and tell us what your PSA is and what Dr. Guercio suggested.
I will do that.
The question I have is, it was suggested to us because we did not, to our knowledge, when Jerry had his radical prostatectomy in 2021, to our knowledge, that was never genetically tested. And so where would we go back to Rochester Regional? Who do we ask to get that done?
Okay, so there's a couple of issues here. Have you ever had a germline test?
No.
See if you have any inherited. Okay. In the chat window, if you scroll up, there's a link to the PROMISE test.
Yes.
And I would suggest you try and get that done right away.
Okay.
Because that's going to be free. You're going to do it through color. Alternatively, if they are tapped out and they've reached their max, then ask Dr. Guercio for a germline test. With your recurrence, it's indicated with the recurrence. All right. We won't get into sort of other history right now, but there's two ways to go. Do you need a somatic test at this point in time? If you do, they should be able to do it with the tissue from your radical prostatectomy, and Dr. Guercio will know how to get hold of that.
Okay.
If he recommends a germline, I mean, God forbid he decides we should do I shouldn't say God forbid he decides we should do a PSMA. If he decides to do a PSMA, which he may well do, it would be reasonable. He may want to wait, but at 0.24 he can probably get a result, and the literature suggests that it's not a great idea to wait. And God forbid that shows some sort of metastasis, then
we already got one, Rick.
I've had that.
Oh, you've had one
in July.
Just this summer, and he's not metastatic. They didn't find anything.
So then I don't think you need to worry about a somatic test at this juncture. Just the germline.
Okay. All right. Well, thank you.
Okay. See you next week. Steve Lodge, you're up.
Okay. Yes. Well, I'll just sort of summarize my situation because some of these folks are new. I was diagnosed with de novo metastatic hormone-sensitive prostate cancer in December of 2021. It would later be classified as oligometastatic cancer. My biopsy had 12 of 12 cores positive with a 4 + 5 = 9 Gleason. My PSA at diagnosis was 4.5. I did have a PSA PET scan, which indicated local lymph node mets and 2 or perhaps 3 bone mets. The tumor was classified MIT2M-N2M1B. They gave me some bicalutamide first, and then I began ADT with Lupron. Shortly thereafter, it was followed by abiraterone with prednisone. I wasn't offered radiation treatment nor a prostatectomy at the time of diagnosis. With the hormone treatment, my PSA went quickly to undetectable. Had a DEXA scan in January of 2024, which showed mild osteopenia, and I started denosumab treatment. After 19 months of undetectable, my PSA started to climb in January of 2024, and they classified me castration resistant. And the prednisone was replaced by dexamethasone. Before my PSA got too high, I did do Provenge treatment. Provenge treatment does not typically affect the PSA, so the PSA continued to increase to 1.07 in April of 2025. PET scan in January of 2025 indicated greatly reduced prostate size, reduced soft tissue mets, and no evidence of bone mets. I started radiation treatment in April of 2025, which was a combined IMRT, SBRT to the prostate bed, lymph nodes, and seminal vesicles. 2 weeks after the end of that treatment, my PSA was down to 0.28, and most recently was at 0.11. I'm continuing on the Lupron and the abiraterone with dexamethasone. The pulmonary, so yeah, sort of at this point, if the PSA stays relatively low or becomes undetectable, I'm wondering what, if anything, I should do, what I should be concerned about. Given my historically low PSA, should I be concerned about any PSA negative or PSMA negative cancers? So, yeah, your thoughts, please.
And the last bit of information, maybe catch us up on your cardiac status.
It appears that my pulmonary embolism has cleared. I've started feeling much better, and started doing too much and injured my shoulder, but that was because I was feeling good, and I'm continuing to feel good. And been to the cardiologist, and or a couple of cardiologists, and they both find that my heart is very good.
And you've been continuously now on Lupron and Abby since 2022?
Yeah, since early 2022.
Okay. 3.5 years now continuously. He's at a PSA now of 0.11, but he did have a nadir of non-detectable years ago. So he's not at nadir. On the other hand, the PET scan showed quite a bit of improvement to treatment. So Steve is wondering, I guess, how long to continue with the present plan, whether to even think about drug holidays.
Yeah, before I just start feeling good and going on with my life, I want to make sure that I'm not missing anything I should be looking at. We're going to obviously continue to follow the PSA very carefully. But yeah, other than that,
And in the background of Steve's mind is, could some type of prostate cancer that is not making PSA or PSMA be sneaking up on him? He's got a little bit of anxiety about that. So, Rick, you want to start off?
Yeah, I mean, I think that you have the best insurance policy of anybody in this group, because your GU Med Onc is Dr. Fong. And I couldn't think of anybody better. And I think I think you need to have this conversation with Larry. You absolutely need to have this conversation with Larry. I think he's going to be on top of it as much as you are. I also think you should be having a conversation with him. If it were me, I would be having a conversation with him about when's the right time to take a drug holiday. Do I need to be concerned about morphing? Have I been on, is it abiraterone you're still on? You did say that. I would definitely, he knows all about abiraterone because he was working alongside Chuck Ryan when they did those tests when the original Zephyr or Zodiac, whatever it was called, abiraterone tests back in the day. So, there's probably a time when it would be good to get off or good to get onto monotherapy or do something different. I would make an appointment with Larry and sit down and say, this is what I want to discuss. And I would feel very, very comfortable. He's one of the top docs in the country, in the world in this stuff. So that's my simple answer.
Yes, I'm seeing Larry in 2 weeks. It'll be my third meeting with him. And yeah, my thought is perhaps it might make sense going to monotherapy, getting rid of the Lupron for a while, but he's pretty comfortable leaving things as is from our.
Well, just, tell him that you're concerned that when people stay too long on the combination, things change, and see what he says. That's what I also wanted to say. I put it in the chat window to Tom McIntyre. Next week, I don't think we can come back to you right now because we're a bit pushed, but we really should be having that discussion with you. It went across my mind when you gave us your history about debulking the primary, because there's a lot of evidence now, even with de novo metastatic people, that at some point after treatment, we should debulk the primary, which is what you just heard Steve did. So come back to us next Monday and we'll talk to you about debulking the primary. So yeah, that would be my response. Anybody else got anything? Anybody else have any advice for Steve?
Here's a question for the group. Steve has had this illness for 4 years now. Is it too soon for him to start worrying about any type of transformation of his prostate pathology? Or considering he has no symptoms and his PSA is low, is there any reason for him to have that worry?
I'm going to pick on, because the hand didn't go up. So I'm going to pick on, he knows who it is because he's already smiling, Dennis Correa.
Yeah, that's a tough one. I think it's ranged. The morphing type stuff is, from what I can gather, it can, of course, start early on, but I think mostly it's later after you've been on maybe 9, 10 years or something like that. It starts to morph. Uh, and you can do some things. I'm in that same boat. And I had an FDG PET done just for concordance with a PSMA PET and found no difference in my prostate cancer tumors where they were. They did find another tumor, and it's they think it is a Warthin's tumor in the parotid gland in the salivary gland here, and it was expressing an SUV of 40, which
Isn't that interesting?
So
Yeah.
I have an appointment with the ENT doc at Mayo for an initial consult on Friday to go up and actually get a clinical feel for it to see what that is, what's going on there, and what the next steps would be. But it's not morphing. That's an entirely different type of cancer. If it is cancer, most of them are believed to be benign.
It's probably going to be benign, yeah.
Yeah. However, if it's a rapidly growing one and it grows fast, it can become cancerous.
Okay.
What I understand.
By the way, I'm going to repeat something I put in my invitation, which is that if anybody doesn't know what we're talking about when we talk about the cancer morphing and the FDG scans, just speak right up. I don't want anybody to be left behind. There's another guy that sometimes comes to this group, and he and I are making a list of terms that we sometimes sling around in this group without stopping to define them so that there'll be a reference. But in the meantime, don't forget to pipe up if we say something that doesn't make any sense.
I'd like to say something. John, did you say a Wharton's tumor in Wharton's duct? Is that what you're talking about, submandibular?
It's a Warthin's tumor is what it's suspected to be based on an FDG scan. There's it's a Warthin's, and that's in the parotid gland.
Yeah, I know where it is, Wharton's duct.
Middle of the salivary gland.
Yeah, so that's kind of rare. I haven't heard of that. John, anybody? Dr. Paul, Wharton's duct tumor, a tumor of the Wharton's duct?
I just know it's usually benign, although it's a pain in the neck.
But it's interesting that the salivary glands do express PSMA.
Yeah.
And that's why you have toxicity. So, I mean, it would be a roundabout way of treating it. I'm sure that someone will think about it.
All right, Steve, are we good?
Yeah, I just mentioned that, I've started using the phrasing, if my PSA starts increasing. I know it's likely that it will, and so I'm not being myopic, but I like being positive.
Okay. I'm not going to really, I'm just thinking, we're going to go on to Mark now, but another question just to think about is, can you think about drug holidays when you're not at your nadir, if you're above your nadir or not? You really have to be at your nadir to think about a drug holiday, or is close enough, But I don't want to open that up now because I got too many guys to get to today. Mark, what do you have on your mind?
So the last 2 weeks have been really hard. I've been going downhill, losing weight, getting really weak. It's hard for me to get out of bed sometimes. Last Saturday, I got so weak and I had a very sharp pain down in my lower right abdomen, which sounded like when my brother had appendicitis. It sounded just like that. So my wife took me to the ER and they did a CT scan, and it was not appendicitis. they just said it was a inflammation, but I've never felt anything that hurt that bad. And it just so weak, like it's hard for me to roll over in bed sometimes. But they gave me a Rollister injection, which is like for constipation. And then they said, go on home and you've got 20 to 30 minutes. And to make it interesting, we got almost all the way home. This is at 3:30 in the morning.
Oh, no.
And a block from our house, there was a van pulled over to the curb with the door open and somebody lying in the street. And I called 911 and cops showed up. The guy had been shot 3 times, and it still hasn't been solved. Anyways, then I told the cops I can't hang around. I got to get back to the toilet. But it actually cleared me out quite well, and the severe pain went away. So I've never realized you could have that much pain from some kind of constipation. But then yesterday, I was supposed to we're checking to see if I could get my next chemo. When we tried last week, my platelet count was so low, the doctor said, no, it'd be unsafe to give you chemo. But they said, give it a week. We came back, got tested again. It was still too low. And I also had my white blood cell, my red blood cell, and my hemoglobin were all fairly low, pretty low. And the platelets were they come up a little bit from the week before, but still at 80, they said they wanted over 100. And then
your platelets were 80. Is that what you said?
Yes.
Okay, thank you. Yeah.
They'd gone down to 74 the week before. They said they don't like to do chemo unless it's over 100. But then Rick has been trying to get me to persuade my doctor to get me some units of blood. And they've always said, oh, well, your numbers aren't low enough. Yesterday they said, you need some units of blood. And so I got 2 units of blood. And today I feel better than I felt in weeks.
I always listen to Dr. Rick.
Yes, exactly. And I've been taking oxycodone at least once a day, usually 2 or 3 times a day, which causes constipation. But this morning there wasn't any pain, so I didn't take my pill. I haven't taken any pain relief all day. That's good. And I've gotten 2 good nights of sleep, which really helps because I have not been sleeping well at all. So right now, I want to keep feeling this way. I feel really good.
Yeah.
But it changes fast. We all know that one day you feel great, the next day you feel terrible. But for the moment, I'm feeling really good. I do have one question if anybody knows about it. I just got one of my blood test results in this morning. My ferritins, which I don't quite understand, the normal is 30 to 330. Mine's at 2,440.
Oh.
What does that mean? Anybody know?
You just had
It's your iron.
You just had a couple of units of blood put in you.
Oh. Well,
I assume that's what it is.
The blood draw was before. Now I'll have to check.
Oh.
I think the blood draw was before I had the infusion, but I'll have to check. I'm not positive. I think I had all my blood done first, and then I had the blood transfusion.
Well, how will they follow up on that? Will they do any iron studies, check iron levels, or you don't know yet, huh?
Tuesdays, my medical oncologist is out of town, so hopefully I'll learn some more tomorrow.
Okay.
One other thing,
Just make sure your liver is okay, you know, from all the iron and all.
Okay.
And also, I was going to say, don't get constipated again. Keep ahead of it because you
Well,
have to take oxycodone sometimes. So, you know, keep up fiber in your diet. Take
yeah,
Miralax every day if you have to. Or
I've got pretty good help on doing that.
okay.
And I don't stay constipated very long. Um, the one other thing is that I've actually gained some weight over the last 5 days, but I was losing weight dramatically. And so I've heard some of you guys talking about cannabinoids to get hungry, which I remember from 50 years ago, but I haven't experimented with it lately. Anybody have any suggestions on what kind of CBDs or what kind of THC will make me hungry? No.
I thought
I think
most
all
of
of them.
THC makes
I
you
think all of
hungry.
them.
We have some good, Oregon, it's legal. There's a lot of dispensaries. And I was feeling so bad last week. I didn't get there, but they seem to know their stuff. So tomorrow, if I'm still feeling good, I'll go there and I'm sure they can help me.
So a
Yeah.
couple of things. I definitely think that you can talk to the people in the stores because they are pretty knowledgeable. I mean, we've got people in this group, I'm sure even right now, who are using medical marijuana. If they would want to speak up. I've seen medical marijuana used to stimulate diet, and it definitely works. I'd also, as I suggested to you, get an appointment with Greta McCare through Rahul. She's terrific.
I've seen her a number of times, so
Yeah, and
should
she's
see me.
great, and she can probably even, I don't know how much she knows about that, but guys, I mean, come on, we got a bunch of people using medical marijuana here. I mean, who wants to give a little bit of advice and some help to Mark on how to balance?
Understanding that you don't actually use it yourself.
No, but I've heard, I would say start with the CBD because it has the least side effects, and then start adding in the THC. Anybody have some personal experience that they want to go on? I mean, I also got the munchies back in the 60s, and that was THC. John?
Um, not cannabis, but mirtazapine. It's an antidepressant. It helps boost appetite, and you can take it in very low doses, very, very low. It also helps sleep. Mirtazapine. That's just an idea. It helps boost appetite and it helps sleep.
John, could you put it in the chat window, please?
I'll try to find it. Mirtazapine. Yes.
Mirtazapine or Remeron, yeah.
Or Remeron.
Remeron, yeah. Gary? And then we're going to have to move on. Gary?
Mark, I wound up actually not taking these recommendations, but I went into a dispensary when I had more symptoms with the prostate cancer, and I was losing weight and not eating, and I just talked to them about my problem, and they basically drew up a menu of what I could take and how it would help me. So I'll just echo what Rick said. If you go in there, they are very likely to have a knowledgeable person who can steer you in the right direction.
Yeah. And can I just add to that? Also, I suggested you get hold of your boy in symptom management. What was his name? Greenberg?
He's off on vacation for another 10 days.
Okay, but then ask to speak to somebody else there. That's okay.
I have been. I have been.
And I also want to say we've seen this blood unit response many times over the years. And, that's why a while back I said, and I'm so glad that it's making you feel better. So don't let them put you off on that one. Don't let them push you off on that one, okay?
I apparently didn't push hard enough, but I know next time to push harder.
Yes.
My gastroenterologist is the one that recommended that I get some CBD, and because a lot of his patients have been successful with it. And he said, but go to the dispensary. He said, they've tried them all. I haven't.
Larry, I have to apologize to you because I'm going to move on. We got 6 people. Neil, would you tell us what's on your mind?
Sure, thanks. Yeah, just take a few minutes. So recently, just a little history. 2012, I had a radical prostatectomy, and that was fine until early 2023, so 11 years. And then I had my PSA started up again, so I had radiation, salvage radiation, and I was on Orgovyx for 13 months until May of 2024. And that was good. I stopped in May of 2024. My PSA recovered immediately to about 200. Earlier this month, I had a testosterone and PSA test. Testosterone was up to 644, which I don't know, maybe that was kind of years ago. So, maybe it's a Quest problem, but anyway, we'll redo it again. My PSA is starting to get recognized again. It was at 0.05. It's the first time it's been detectable since April 2023. We did a DEXA scan in 2023 and a DEXA scan again in early 2025, May of 2025, and I just got the results through my urologist, and I've lost minus 2.18% on my lumbar. My hip is fine. It's lost a little bit, 0.01, but kind of concerning at the minus 2.18% over the 2 years. And so I was with my urologist and yesterday, and he gave me this information, and he suggested I go on Prolia to shore up the bones. And I do have an appointment with Agarwal, my GU in Raul, in November. And I intend to kind of wait to see what he says. I sent him a note today to see what he says about it. But I guess my question is really Prolia and or, I'm mildly osteoporotic.
Well, you're not even quite, you don't quite make a definition of osteoporosis yet, but you sound like you're well on the way. And so the question of whether to use treatment at this point or wait until it gets worse is something you'll discuss with Agarwal. Are you, by the way, exercising, taking calcium, taking vitamin D, all that stuff?
I exercise a lot, and I do not take calcium. I take vitamin D.
See what your doctors think about adding maybe 500 or 600 milligrams of calcium twice a day to your current regimen as well. Somebody surprised me earlier in the evening who had only osteopenia and was on denosumab. I was a little surprised that they had jumped to a monoclonal antibody in somebody without severe disease, but it sounds like there might be a trend toward coming in with treatment a little bit before you actually become osteoporotic. Len, do you have any comments about that? Or Rick? Is it too soon to start meds or not?
Yeah, I think he has no Mets. Is that right?
No Mets. No Mets.
Yeah, I wouldn't I certainly wouldn't use denosumab, but I think Prolia is the better indication for your condition, osteopenic. That's what they use it for. Denosumab is used, to my knowledge, by its approval status, just for patients with metastatic bone cancer.
But hold on, Len. That that's Xgeva.
Yeah, that's denosumab.
Right, but
okay, yeah. There's the two doses.
Prolia, which is also denosumab, is a lower dose.
Right, the lower dose. Right.
And so the Prolia may be appropriate right now. I don't know if I'd want to wait. I mean, I was osteoporotic when I was diagnosed, minus 2.5 in my spine. At that time, back in the day, they gave me 3 shots of Zometa. But I'm not sure I really see the downside in taking some Prolia and seeing how you do. The other thing is to try and do some weight-bearing exercises on your spine, which are hard to come up with. What I was doing at that time, I don't think I could even do it now, was squats with a bar on my shoulders. So that was kind of stressing the spine, because most exercise that you do, it doesn't really stress the spine. And so that, if you have an exercise counselor, a trainer, ask them what you can be doing to stress the spine, Neil. But
yeah,
I wouldn't wait.
Okay.
The specialist that knows the most about this is the endocrinologist. So if you want to get an expert opinion, that would be the person to go to.
I have one in the UCSF, Dr. Holt.
Good.
So maybe I'll send Dr. Holt a note. But yeah, I do a lot. Most of my exercises, Rick, are around the core, so spine and in front, and I do spend a lot of time at that. But
yeah, but the thing is that those core, because I do a lot of core exercises too with my rowing. But what we're looking for is something that really sort of puts stress on the spine. It's not sort of the flexibility. And what you might want to do, make an appointment with the exercise counselor at UCSF. They've got a program there, and just ask them about that. And also definitely ask your endocrinologist.
Yeah, I will send that off right away. One of the things I heard about Prolia is that, it's a shot every 6 months. And I just, one of the thoughts was, someone was telling me that, once you start it, you really can't get off it. So maybe there's some incremental stuff like calcium or others that I might want to try first. But sounds like my endocrinologist might have a better feel for this.
With apologies to Thomas, I'm going to go right on to Jim Cavanaugh in the interest of time.
Thanks.
Yes. In short, I was in the hospital last night. My primary basically understood that I continued to lose weight. I'm 7 pounds down to 124, very thin. I have no appetite. I'm only eating 2 meals a day, and versus 3. I'm snacking wherever I can just to try and load up, even though it's not the best diet. But I'm not making any progress. Extremely tired. My testosterone is down to 0.7, where I understand it should be at least 265 in my age bracket of 82. The good news out of the whole thing is my Orgovix. I just finished up with it for 8 months and have imperceptible or unrecognizable cancer with 2 tests. That's the good news. But the bad news is I have no energy, and I'm believing I need to get my testosterone up because I can't can't function. So they sent me to the hospital for additional tests, just in case there was something else that my primary is missing. I've gone off the Orgovix 10 days ago, and his only thought was, well, we'll retest in 3 months from now, put you on Lupron. I also was in contact with my radiation oncologist who put me on the 5 treatments back in February. Very intense. I was sleeping 14, 16 hours a day. I'm now sleeping 10 hours a day, but I've also been diagnosed with severe sleep apnea. I just got the machine yesterday. When we finish on this session, I plan to go ahead and use it. They also detected, because they had recommended with what was going on, I needed to strengthen the muscles in my lower extremities. Unfortunately, even though I had a doctor who seemed quite good, the pressure on my glutes triggered a problem where I have my right buttocks is a 9 and just very difficult. So everything's kind of pulling up. I have a heart background. I have kidney issues. So different things that have come up, and I can identify with things in pockets. But I kind of got a little bit of a lot. I'm not making any progress, and I need to know, where do I go from here?
What kind of machine did they send? BiPAP?
It was a BiPAP. He said it was a very complex type situation, so the CPAC was not good enough.
Okay. So what we're hoping for is between BiPAP and being off of ADT, that some of your energy will come back.
I'm hoping so. I did check with my heart doctor that basically my left ventricle was would be able to handle the BiPAP.
Okay. Yeah, it was the ASV I was more worried about. I'm glad that you got BiPAP. And your cancer itself, what was your last PSA?
It was about 3.5 weeks ago, and it was imperceptible.
Yeah. Oh, yeah.
And that was the second reading.
Yeah. Orgovix mono.
So I'm believing I've got to get my testosterone up, and I don't know if there's any thoughts.
Well, the testosterone will recover. Fortunately, you're not on a drug that's going to last for months and months. We're all hoping that you have a detectable decent testosterone level by the end of the month. And oftentimes people who get on a positive airway pressure machine will have a significant gain in alertness and energy quickly if it's a severe disease. You have mixed central and obstructive sleep apnea. It should be able to treat both. I'm really hoping you'll feel better by the end of the month, and maybe even in a few days if the breathing machine kicks in well. Other comments? I see Neil's got his hand up.
Yeah, I just wanted to say that, Orgovix, I was on monotherapy with Orgovix for a little over a year, Jim, and it took about, 3 or 4 weeks before my testosterone came back, but it started bouncing back, and every month after that, it's gone up quite a bit. So it's just going to take a little bit of time from the Orgovix specifically.
That's good. Thank you.
Thank you. And of course, the pain is also kicking your ass. Okay, I'm going to go on to Ed. Rick, is it okay if I go over a little?
Yeah, go over as long as 15 to 20 minutes. Jeff Marchi says, what about low cortisol? But he hasn't been on abiraterone. You haven't been on any steroids, correct, Jim? Have you been taking steroids?
No.
No. So, my only thought was, what do the blood CBC? What do the complete blood counts say? And I mean, it sounds like there could be something else going on, but that's well beyond this group. But I would just be pushing whoever is you feel is your quarterback doctor to be looking for other causes beyond the sleep apnea. John, back to you.
Yeah, make sure you're not need a couple of units like Mark did. I'm going to go on to Ed.
Good evening, everybody.
This quickly, or do you have to wait till next week? Or go ahead if it's not too complicated.
It's just a quick question.
Great.
I'm in my 14th session of 38 radiation treatments. I had asked the doctor about bike riding because I like to bike ride, and he kind of suggested not to do it at this time. What is the harm in if I were to go out riding? Any opinions?
Well, let's assume that your rectum is taking some radiation, and that it's a little bit angry, and then you put pressure on it with the bicycle seat, and I suppose it could trigger off diarrhea or bleeding.
Okay, I don't want that. So I guess I'd be hiking a lot instead of biking.
Maybe for the time being. I know my colon didn't like radiation treatment very much.
All right.
I remember when I did my radiation, I tried to walk 30 minutes every day. I don't think I did any rowing or bicycling, if I remember correctly, but I honestly cannot remember. I don't know what anybody else who did salvage radiation, were they advised not to ride or to be careful what type of exercise they did? A lot of you have done salvage radiation here.
I know jogging used to trigger off episodes of diarrhea when I was doing it.
Yeah. No hands yet. Keith Lawrence, please go ahead, Keith. Good to see you again.
Yeah, thanks, Rick. It's only been a few days.
Yeah.
And Rick, I have no direct experience in this space, but I'm coming off the PCRI conference where I saw Rick, and there was direct mention around concern around bike riding and radiation. Honestly, I kind of let it go over my head because it's not my space, but I did hear that. And very few other, but specifically bike riding came up.
Okay.
When I went through proton radiation 10 weeks, I rode my bike every day to the hospital.
John M., what's on your mind tonight? You still with us, John? If not, I'll go to Herb. Is Herb still here?
Just
hold on.
John. Hold on a second, Herb. Let's just at least roll up.
Sorry, Herb. John is here. What's up, John?
Ed.
Very briefly. Go ahead, Rick. You have the floor. You have the floor, Rick.
Okay, just for a second. Ed, what I would try and do is see if there's any exercise support at you're doing this through Yale, correctly? Correct?
Yes.
I would call their cancer support office and see if there's any exercise support through that, and speak to whoever you can there about their view on bike riding and during radiation. You're safest if you just walk, but if you would like to do it, as you heard, we have a gent who did do it, but we also heard that maybe you shouldn't do it. So we're getting both sides, but I would rely on What's it called? What's the name of the cancer center at Yale, Dr. John?
Smilo.
Smilo. So I would see if there's somebody at Smilo who can help you with that.
Okay, John, and then Herb, and then if there's still any time left, Dennis.
Yes, this is just a real brief note, and I'll put a link in the chat. A week ago, I did a 1-hour talk about my poetry and my cancer on Solo Arts Heal. And I wrote a book of poetry in 2022 called Hammering Nails, and all net proceeds from the sale of the book in the month of September will be donated to AnCan. And I'll put a link. I'll put a link to my book on Amazon, and I'll put a link to the video.
So it's pinned. It is pinned at the top of the chat. If you scroll up, you'll find it pinned at the top of the chat. All of the information.
Thank you, guys. Herb?
Thanks to John Maxwell too. It was a great session. We loved it. Thank you, John.
Thank you.
Go ahead, Herb.
Okay, well, just a little bit of an update. You know, I went off doublet therapy, Lupron and darolutamide about 2 years ago, and I've just been on darolutamide, and my PSA is bouncing around between a low of 0.03 and a high of 0.06, so it's just pretty steady, and everything's good on that front. Dr. Rettig, of course, is my GE med onc, and I couldn't be happier with him. But a couple of other just quick comments. One of the side effects, even with just the darolutamide, has been leg cramps. And I ran across an article from, I think, the Cleveland Clinic that said that there was some indication that B complex vitamins might be helpful in mitigating leg cramps. And I was taking B12, so I thought, well, I'll just switch over and take B complex. So I started doing that, and then all of a sudden I realized after about a week, I thought, hey, I haven't had any leg cramp in the last week. And anyway, been doing that now for about 4 or 5 months, and the leg cramps have been dramatically reduced in both frequency and severity. So I know everybody's different, but anyway, I just throwing that out. And then
it's really good to hear, because the problem comes up fairly frequently, and that's really good to hear. I think Rick himself had some benefit from a B vitamin for his leg cramps too.
No, for me, CoQ10 is what helped.
CoQ10, okay.
And I take a CoQ10 at night. I recommend B6 for neuropathy. That's where the B comes in for me, but CoQ10 is another. But if it ain't broke, don't fix it.
Yeah, right. Well, and I was taking B12 just for energy, although my energy's good, but the B complex, and you have to be careful because there's some things that are advertised as B complex, but they don't have every single B complex in them. But anyway, it's helped me. So the other thing I've had ever since I was a kid was restless leg syndrome. And I ran across another article that indicated that magnesium might be, again, helpful. And I started taking that about a month ago, and that seems to be helpful. I don't know if it's just my imagination or not, but I swear it's again the severity and the frequency of the RLS, which always is at night, in the middle of the night after you wake up, has gone down. So just like I said, I know we're all different, but I'm throwing that out there as something you might try if you have either one of those issues.
That's very helpful. I have heard of people responding to magnesium supplements, and for that also, sometime early, I think it was early this year, I wrote an invitation on leg cramps. You can dig that up if you want. There's a few comments about restless leg syndrome. So keep an eye out for any of us that complain about leg cramps and bring that up again, Herb. That's very helpful.
Okay, thanks.
Dennis, you want to get the last word in?
Yes, leg cramps, I've had that same problem, and hydration is also important. You got to stay well hydrated. I'm down in Tucson here, and it's pretty hot and dry this time of year, so I got to really force myself to drink a lot more than I can't wait till I'm thirsty. But that's helped. And then in the middle of the night, if I get it, I've tried this product called TheraWorks for muscle cramps. They make a number of different things. It comes in a little pump can. You just get up and you rub that stuff in, and within a minute, the cramp is gone. It can be quite painful, I know. I've
Yeah,
got
TheraWorks.
feet and legs.
TheraWorks works.
Yes, it does.
But I was trying not to get them in the first place.
Yeah.
Yeah.
Dennis, did you have something else to bring up?
Well, I did. I was going to talk about that Warthin's tumor a little bit, but
Okay.
we covered that pretty good. The only other thing I've got is I've got an appointment with my RADOC, my radiation oncologist, to see, because I'm still shooting at this back pain issue that I have. It's chronic, and rather than just, I take some drugs, put the ice and put the heat on and stuff, get some relief. But I'd really like to know what's causing my pain. It's not an increase in my PSA. My PSA is stable, very low, down to 0.1 or 2 or so. But I was going to meet with him just to see if he could take a look at my latest scans and so forth, and see if he thinks he can give me any pain relief with palliative radiation to any of my bone issues. But I know I've got arthritis down there too, so I've also set up an appointment with my GP just to get her take on how do I go, what type of specialist should I look at. I mean, a neurologist, neurosurgeons, everything from there to, and I've looked at the osteo part of it. Had somebody, they looked at a scan and said, oh, it looks like your spine, you've got all this arthritis, bone spurs, and so on. And it looks like right here, your facet joints, I guess, on the spine and the lumbar was impacting the medial nerve. So they're going to do an RF ablation, but first they have to do a test with a lidocaine injections.
Yeah.
It's supposed to make your pain go away for at least a couple hours.
They'll inject the medial branch of the nerve and see diagnostically
It
whether
never
the pain goes.
so it never went away. So that's not going to work. So I'm just chasing this thing down. It's impacting my quality of life. My sleep. I can't play. I'm concerned about going out and playing golf because it almost feels like something's going to snap off down there. But as far as I know, I don't have any fractures in my vertebrae. I don't think it's a muscle issue. I've had this since early May. So
maybe a neurosurgeon would be appropriate.
Yeah, because I do get some weakness and kind of numbness in my right leg at times when I'm doing I do some yoga stuff too, stretching, and my right leg always seems when I get that little bit of numbness in there.
So, John, Dennis, the one thing that concerns me whenever I hear people with long-term prostate cancer with back pain is I want to make absolutely sure that there is no metastasis has crept in, even if your PSA is undetectable. And when was the last time you had a PSMA scan?
That was last year. And then I've just had the FDG scan to compare. And
right. And when did you have the FDG scan?
That was 5 weeks ago, 4 or 5 weeks ago.
And there was nothing that showed up in the spine on the FDG scan, correct?
It was in concordance with the PSMA PET.
Okay. So, okay. I mean, that's my biggest concern. I mean, in this group, we really have to stick to sort of prostate cancer issues. And my biggest concern is that there might be some weakness in the spine from the prostate cancer. I think that's where we should focus. Beyond that, I don't know what else we can, that we're really qualified to help you. And
Yeah,
if you're comfortable.
Some of the side effects from like Prolia, I read the study results there when they put that through the trial, and there was a number of people that had back pain as a result of it compared to the placebo.
As a result of what?
Prolia.
Oh, Prolia.
Prolia.
Okay.
I think we have heard that.
Did you hear that? Anybody?
Yep.
That. Yeah.
All right. And I think we have to close up, but Mr. Koo, or some people call him Mr. Prez, that's Bill Franklin, our Chief Operating Officer and Board President, has put a very good note in the chat that mustard packets may help. I'm wondering if that's that green mustard, that green Japanese mustard, because this was from a karate sensei. So I don't know.
Just a regular yellow mustard packet from like you'd put on a hot dog. He kept them in the dojo, and students would complain about a cramp. He'd make them suck one down. He only ever did it once, but I maybe it was just the power of suggestion, but it seemed to work.
Gotta love it. John, could you hold on just for 2 minutes, and everybody else, we're going to throw you out the room before the multiple sclerosis folks come in. By the way, if you know anybody with multiple sclerosis, please tell them to come to this group. Okay, goodbye.
Good night,
Good night,
everybody.
everyone.
Sorry
Bye-bye.
you didn't get